Broadly speaking, you can categorize SVT into two different categories: reentrant SVT and focal SVT. So reentrant SVT is a re-entry mechanism mediated SVT, and Tash goes through a lecture on the mechanisms of re-entry and how re-entry works in the previous lecture, so visit that again if you've forgotten. But essentially, these are patients who have been born with anatomical variations, so they've had these anatomical variations of their heart from birth, and those anatomical variations predispose them to developing a reentrant arrhythmia. Now, they may not have their reentrant arrhythmia at birth. They may be 8 years old or 15 years old or 25 or 35 or 45 or 55 or even 65 years old by the time they have their first reentrant arrhythmia. But most of the time, it occurs at a fairly young age, below the age of 40 years, often in their 20s or even earlier, sometimes 30s. And these patients will describe experiencing palpitations or fast heart rate or dizzy spells in most cases. So the two different types of reentrant SVT, which I'll just broadly go through now because we're going to go through them in more detail in the subsequent slide, are AVJRT. So the first is AVJRT, and I'll tell you what this stands for in the next slide. But for now, AVJRT is a reentrant circuit which involves anatomical variations close to the AV nodal region, so in the lower part of the right atrium. And then the second type of reentrant SVT, I'll do in purple, let's do a different color here, so is called AVRT. So very similar names, AVRT. So AVRT involves an anatomical variation where a patient has a bridge of myocardial tissue spanning the mitral annulus or the tricuspid annulus. And this bridge of myocardial tissue allows conduction to occur across the mitral annulus in a region that, or in addition to the AV node. So usually the AV node and the His-Purkinje system is the only spot where conduction can occur from the atria to the ventricles, or from the ventricles to the atria. But some patients are born with an anatomical variation where there's an additional or accessory pathway of conduction. And these are known as accessory pathways because they're an accessory or an additional pathway of conduction other than the AV node that crosses the annuli. And they can occur anywhere along the annulus. It can occur in the tricuspid annulus as well. And that enables a reentrant arrhythmia to form between the AV node and the accessory pathway, and that's known as AVRT. And so both of these are anatomical variations that are present from birth, although symptoms may manifest later in life. They're generally prognostically benign, and treatment is usually based on symptoms. How much is this affecting your life, and how badly do you want it treated? The other mechanism of SVT, in a very broad, low-resolution way, is a focal mechanism. So a focal mechanism is usually what we call focal atrial tachycardia. And so focal atrial tachycardia is most of the time not a reentrant mechanism. So it is what we call a focal mechanism. So where for whatever reason, let me fix up my heart here. For whatever reason, there's a group of cells in the heart, and it might be coming from the mitral annulus, like this. It might be coming from the coronary sinus ostium. It might be coming from the left atrial septum. It can be coming from all sorts of different locations in the heart. But for whatever reason, there's a group of cells in these regions which are spontaneously depolarizing faster than the sinus node at more than 100 beats per minute. So they're just firing off depolarization spontaneously. And there's a few different mechanisms that causes this. Sometimes a patient can have electrolyte abnormalities, sometimes a patient could be hypoxic or ischemic, and that can trigger this kind of activity. And sometimes it's idiopathic. We don't know what the cause is. It's just happening and we don't know why. The patient's 20 years old, there's nothing wrong with them, they don't have any heart disease. There's no explainable reason. It's just a group of cells misbehaving for whatever reason. And sometimes it gets worse with exercise, sometimes it's suppressed with exercise. So there's a few different kind of mechanisms to this. And sometimes it's actually a really super tiny micro reentry circuit. So you have a really tiny micro reentry circuit that's forming, and that is more common in patients who are 60, 70 years old who have had some age-related remodeling in their heart. But generally speaking, focal SVT can occur in anyone as well. It can occur in a 15-year-old, it can occur in a 40-year-old, can occur in a 30-year-old, an 80-year-old, and there's different subtypes of this focal atrial tachycardia in terms of the mechanisms, but we generally broadly refer to all those subtypes as a focal atrial tachycardia, a group of cells depolarizing faster than the sinus rate, more than 100 beats per minute. And what's nice about these two broad categories of mechanisms, reentrant SVT and focal SVT, is that they both have distinct ECG characteristics. And we'll go through that now.